Isogus asked me to give 2 lectures. As I said in the beginning, this is the second lecture, and we'll be focusing on the typical ultrasound appearances of abnormal findings that you might find. Okay, sorry, we're ahead of our time. This isn't advancing, so I'm going to have to... sorry, there's no picture here. Yeah, but this isn't advancing there. Let's go here. Oh, that's fine now. Where is that? No, it's not following. Should we escape? So this is not following for whatever reason. We'll close and open.
Which number was it?
It's 5.
Where is 5?
Also, lecture 5. That's the 5. Lecture 5, yeah. Abnormal findings, yeah. Yeah, good. Yeah, that's what I've been using. Yeah. Okay. Okay, good. Thank you. Right, so hopefully by the end of this lecture, you'll be able to compare the differences between typical normal and common abnormal appearances presenting in gynecological ultrasound examinations. So the key questions which you want to answer is how do the ultrasound appearances of fibroids and adenomyosis differ? What are the typical ultrasound features of the most common endometrial and intercavitary lesions? What are the typical ultrasound features of the most common pathologies in the adnexae? How do I describe ultrasound findings using standardized protocols of IOTA or AITA? And which patient should I refer for a second opinion? Okay, so the basis for ultrasound diagnosis in gynecology is grayscale ultrasound or pattern recognition. If you're using Doppler, you must be familiar with the Doppler physics, understand the pitfalls of Doppler, and be able to recognize Doppler artifacts. So if you're not set up correctly and you put on your color, then everything will appear abundant color, and you'll overcall a lot of lesions that have got absolutely no color. So your Doppler settings must be correct, and we speak of a PRF of 0.3 to 0.6 kilohertz. So the most common myometrial pathology you're going to see is myomas, fibroids, and adenomyosis. And sometimes you actually see a combination of both. So 40% of the time you're actually going to see both. So myomas, the most common myometrial pathology, is recognizable by round, oval, lobulated, solid tumor casting shadows. Sometimes they look quite hyperechoic, and at other times you get cystic degeneration, and you can have all kinds of cysts in the fibroid. So once again, a typical myoma is round, oval, lobulated. It's a solid tumor, and it casts stripy shadows. In contrast, adenomyosis is a condition where you have endometrial stroma and glands in the myometrium. The consequence of that is you get myometrial hypertrophy. So your uterus, which has got adenomyosis, is enlarged. This might be asymmetrical enlargement, or it might be symmetrical. You tend to find this fan-shaped shadowing. There are cysts in the myometrium, and there's poorly defined endometrial-myometrial junction. So to give you an example, so you can see the asymmetrically enlarged uterus with the anterior wall being thicker than the posterior wall. You might see fan-shaped shadows, and they speak of rain in the forest. So basically that's the specific term that we use for looking for adenomyosis. Okay, in terms of cysts, if you're seeing any cysts in the myometrium, it's basically adenomyosis. There's nothing else they call cysts. Your only differential diagnosis is putting color on, because sometimes it's a vessel. But in terms of sensitivity and specificity, There's a recent publication by Katerina Exoscousas, and in her publication, if you see myometrial cysts, it is the most sensitive and specific for the diagnosis of adenomyosis. And then you have this poorly defined endometrium, and it's often difficult to get your measurement, and you can sometimes see pockets of endometrium in the myometrium. So the most common intracavitary pathology would be a polyp, submucous myoma, hyperplasia, and cancer. And currently there's no ultrasound features that are suggestive of hyperplasia. So effectively you can only tell the difference between a polyp, submucous myoma, and your hyperplasia and your cancer have a very similar ultrasound appearance. So your polyp is a hyperechoic structure that you see within the endometrium. You often see this bright edge surrounding it, where the polyp and the endometrial surface abut. There might be cysts within the polyp surface itself, and Dirk Timmerman looked at a feeding vessel. So if you put your color on, you might be able to ascertain that there's a single vessel that feeds that polyp. In contrast, the submucous myoma, well, it's a solid tumor projecting into the uterine cavity, and it generally has the same echo density as the surrounding myometrium. If you put your Doppler on it, though, you might see a ring of color around the myoma. Ultrasound features suggestive of endometrial cancer, so it's a very thick endometrium. It's inhomogeneous. Often you can't see the endometrial myometrial junction particularly well. And if you put your color on, it's either richly vascularized, or sometimes you can see multiple feeder vessels. Okay, so we talk about ovarian pathology. So a lot of women will present themselves for routine for pap smear. Before they know it, they've had a transvaginal scan and they're diagnosed with a cyst. And depending on how good the person who's doing the ultrasound is, before they know it, they're also having a laparoscopic cystectomy for essentially completely benign cyst. So benign ovarian pathology is incredibly common, and it's also you often find that these patients are completely asymptomatic. And if you've heard of IOTA, one of their plans is to follow longitudinally women with benign cysts to see how often they complicate. So if you see a cyst that's essentially unilocular, it's got anechoic content, the top one on the left, that is essentially a follicular cyst or a simple cyst. And anything up to 4 millimeters we can consider completely normal. They may actually, in actual fact, be bigger, and you can actually follow conservatively a cyst even up to 10 centimeters. Okay, as long as it keeps those features. The risk of malignancy in these cysts is incredibly low, especially if they've got no color in the wall and the cyst remains thin. Other common cysts that you might see is a corpus luteum cyst, and that's characterized by the spider web appearance that you see in the cyst, and then you have dermoids and you have endometriomas. So just to go back to the follicular cyst, so it may also be a serous cyst adenoma or mucinous cyst adenoma, and that you can't appreciate on ultrasound. But those are all still in the benign types of cysts, so they can still be watched. Okay, so right, these are all features of dermoid cysts. Okay, so the typical feature of a dermoid that you'll see is that Rotitansky nodule, where it's that bright white lesion, which is effectively a combination of hair and sebum. You also might see these dots and dashes, and effectively what those are, that's often hair that's suspended in the sebum. And you're seeing the hair either as strands longitudinally or in cross-section like that. And then the other characteristic feature of dermoid cyst is shadowing, because that hairball either absorbs the ultrasound beam or it reflects it. Endometrioma, on the other hand, it's a unilocular cyst. Normally it's got a thin wall, sometimes it can be quite thick. Generally they're quite tender, and it's not the cyst that's causing the tenderness, it's the adhesions that may be around the cyst, and the content is described as ground glass appearance. Sometimes there might be some nodularity in the wall of the cyst, and it's thought that this might be to an old blood clot or fibrin deposition, and it's of no real consequence. So in terms of your practice, these are the most common cysts you're going to see: follicular cyst, simple cyst, corpus luteum cyst, dermoid cyst, and endometrioma. And 50% of all the cysts that you're going to see will be one of these. In terms of extra ovarian pathology that you might see a hydrosalpinx, paravarian cyst, or peritoneal inclusion cysts. So how do you diagnose a hydropyomatosalpinx? Essentially, it's if you're seeing a longitudinal sausage-shaped cyst with incomplete septations, the chances are that is a cyst. And what actually happens with your cyst, you can imagine if you've got an fallopian tube like that and there's an inflammatory process, it basically bends back on itself. So what you're actually seeing is the wall of two parallel, a parallel tube, and that's why you have that incomplete septation. Likewise, in cross-section, if it's acute inflammation, then you get inflammation of the mucosa that gives you the cogwheel appearance in that middle slide. And with chronicity, you'll get burning out of that inflammation. The mucosa is then destroyed, and then you see the beads on the string appearance, which is the cyst on the far right. So, sausage-shaped cogwheel, beads on a string, incomplete septations. And this is a slide that shows all features of that. You see your sausage-shaped hydrosalpinx, you see your incomplete septation, and that dot is the bead on the string. So is it possible to differentiate between an ovary and a paraovarian cyst? Well, first of all, what is a paraovarian cyst? So a paraovarian cyst develops from cells in the fimbria which have embryological origins. And essentially it looks very much like a unilocular cyst that you would see in an ovary. How you distinguish between the two is the usual probe, much like we showed with that dynamic assessment. If you put your probe between the paraovarian cyst and the ovary, you can often separate it off. It's sometimes easier said than done. Sometimes it's quite attached. And then you have to follow the contour of the ovary with two views to determine that this is a paraovarian cyst. In terms of peritoneal pseudocyst, is it possible to differentiate an ovary from a pseudocyst? And the answer to that is yes. What is a peritoneal pseudocyst? It's called a pseudocyst because basically it's a collection of fluid in the pelvis that arises secondary to an inflammatory process, for instance like appendicitis or a PID, or it might arise secondary to a previous laparoscopy or surgery. And essentially what it is this free fluid that's trapped within the adhesions. And to go and find your ovary, you normally find it on the side, or sometimes you find the ovary right in the middle. Fine. So the rules of thumb in differentiating between benign and malignant adnexal pathology. So I've shown you what a follicular cyst, corpus luteum cyst like. You've seen what a simple cyst looks like. Hopefully you can recognize a dermoid and an endometrioma. Okay. So if you can't recognize that, then generally as a rule of thumb, if your cyst that you're seeing has got any irregularity in it, then you consider that this is malignant. There's an exception to the rule, and that's a multiloculated cyst, which kind of has a Swiss cheese appearance, and this is typical for a borderline tumor of the mucinous subtype, gastrointestinal subtype, of a mucinous cystadenoma. Okay, so to talk about terms and definitions, it's very important that we all talk the same thing, and we all understand each other. My present bugbear is how often I still hear the term complex ovarian cyst, bearing in mind it kind of disappeared from ultrasound parlance about 25 years ago. And I always tell the students, when was the last time you spoke about toxemia in pregnancy? And they kind of look at you this way. But that's one term that we use all the time, and we actually shouldn't be using it because it doesn't actually describe what you're seeing. So the second reason, so I'm just going to go back again, why we need terminology that we all understand is because we can compare scientific studies. We can then compare meta-analyses because we're all talking about the same thing, and we can conduct multi-center studies. Okay, so the one thing that ISIOG has done is there are consensus guidelines now. So a number of years now there's been IOTA, which has basically looked at terms, conditions, and the way we measure ovarian tumors. There is the ITA, which is the examination of the endometrium. Recently, there's been the MUSA, which is the myometrium, and then last year, I think August, there was the release of the IDEA, which is the endometriosis consensus statement. So if you're interested in gynecology scanning, then I suggest you read all four. They're available online and they're very easy to access, and they have great pictures and it's easy to understand. Okay, so basically what I want to do in the next couple of minutes is just take the aorta and look at the way they describe an adnexal mass, so you can kind of see what we mean by speaking the common language. So those are all the features that they mention in the paper: solid components, papillary projection, type of tumor, echogenicity of cess fluid, shadowing, ascites, and the color score. Okay, so the aorta definition of a solid component is any structure that you see within the cyst that has an echogenicity that's similar to surrounding structure, so be that myometrium or the ovarian stroma. Okay, so a white ball of a dermoid cyst is not a solid component. Okay, and a blood clot or other amorphous material is also not a solid component. Often, if you're struggling to determine whether you're actually seeing a blood clot or any amorphous or solid, then you push on the lesion. And what will happen if it's fluid or it's a blood clot is you actually will see movement within that or compressibility, whereas you're not going to see that with a solid cyst. The other thing that you can possibly do is you can use color Doppler, because if you put on your color flow and you see flow within your solid lesion, then it is a solid lesion. If you're not seeing flow, then it might be that your your ultrasound machine isn't set up properly and that your Doppler doesn't work, or it might be that there isn't any flow within it. And the other thing you can do is the shape. So if there's this concave appearance of it, then it's also not a solid lesion, because solid lesions tend to be more circular. But obviously, if you're in doubt, then call it solid. And if you, because the consequences of missing a solid lesion is that the potential for malignancy is a lot higher, and therefore you might be missing a potentially malignant condition. Okay, in terms of the outer classification of a papillary projection, this is a solid projection of tissue into the cavity that needs to be 3 millimeters in height. So that's 3 millimeters from the base. If it's less than 3 millimeters, then we speak of an irregularity. So all papillary projections are referred to as solid structures. Okay, so the original paper describing cysts came out 25 years ago by Seth Granberg, who's kind of one of the godfathers of ultrasound. And way back then, 25 years ago, there was no talk of complex cysts. You can describe a cyst as unilocular, which essentially is a cyst that has got no follicular projections in it at all. If you see a irregularity and it constitutes something that's more than 3 millimeters above the wall, then it's seen as a unilocular solid cyst. A multilocular cyst is a cyst that has no solid components, but all you've got is multiple loculations. If you see solid components within it, then it's a multilocular cyst and solid. And finally, you have solid cyst. And these are all important because your risk of malignancy is based on the structure that you're looking at. So as I said previously, if a unilocular cyst that tends to be less than 10 millimeters, there's a very exceedingly small chance of it being malignant. If you're seeing a solid cyst, it's a 60% chance of malignancy. So that one you need to take very seriously. They also have ways of describing the cyst content. So anechoic is when you have absolutely no shadowing within that cyst. Low-level echoes is when you start seeing some content. Obviously, ground glass, you start thinking about endometriomas. Hemorrhagic gives you that spider web appearance. And then sometimes you see a mixed, which may be a corpus luteum, may not. In terms of shadowing, there are different types of shadowing, and that basically depends on it's obviously the beam passing through the cyst that you're looking at and the degree of absorption that happens. And then finally, there's ascites. So this is all fluid outside the pouch of Douglas. So as a general rule of thumb, if you're seeing fluid in the pouch of Douglas, it's not ascites. If you're seeing fluid that you can see up to the level of the fundus, or you're seeing it between the uterus and the bladder, it's significant. And it really, really is significant that if you scan up in the liver and you see fluid between the liver and the kidney. So for those ruptured ectopics where there's a liter in the abdomen, you're going to see fluid in that space. In terms of color score, once again, there's a standard color score. So if you put your Doppler on and you're happy that it's working properly, if you see absolutely no color, then it's a color score of 1. If you see some color, then we score a 2. Moderate color is 3, and if there's abundant color, it's 4. 1, 2, 3, 4. Okay, so once again, you must make sure that your ultrasound is set up correctly. Fine. So in terms of measurements, when we measure ovaries, when we measure fibroids, when we measure papillary projections, you should have 3 orthogonal measurements. So essentially, it's this. So you want to measure your ovary this way, and this way. So what you should be doing is I always split the screen because I find that easier. You turn your probe 90 degrees, then you freeze out the image, and you have all your both images. And often the ultrasound machine makes it very easy because you go pop, 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 and pop, pop, and you get all your measurements. So you should measure the maximum diameter, and your ultrasound machine will automatically calculate the mean diameter and the volume for you. So that's essentially the way I do it when you scan. You split your screen, you have the cyst, and you do all your measurements in one. In terms of papillary projection, you measure the largest papillary projection. Once again, your 3 orthogonal measurements. You do not include the wall of the cyst, and then you'll get a measurement. In terms of IETA, this is the consensus statement on the description of the endometrium and the terms. I'm not going to go through the entire one for you, but we're just going to look at the intercavitary lesions, and that's defined as any lesion that projects into a fluid-filled uterine cavity. And to just quickly talk about the difference between pedunculated and sessile. So if the base of your lesion is smaller than the top of the lesion, then we speak of a pedunculated lesion. There's obviously a formula that you can work it out on. And if the base is wider than the top of the lesion, then it's sessile. And once again, the scoring for the endometrium is similar to the scoring for the ovary in terms of they're not trying to complicate you. You have a score of 1 to 4. So if you see no color flow, it's a score of 1. Minimal color flow, score of 2. Moderate is 3, and abundant color is 4. Once again, when you get your ultrasound machine for the first time, you can actually get your techies to sort it out properly, and so that you don't find color in every little lesion that you're looking at. Okay, in terms of which patient should I refer for a special opinion, so those who you're uncertain about a diagnosis, especially if you suspect malignancy. So the key point that we should quickly go over, common uterine pathology is manifested in typical ultrasound appearances. Hopefully you'll be happy separating a myoma and adenomyosis, polyps, and then endometrial cancer. So common cystic structures in the adnexae where the typical appearances are, as mentioned previously, a functional cyst, simple cysts, dermoid cysts, endometrioma, hydrosalpinx, paravariant cysts, and inclusion cysts. Okay, so for all other pathology, if you can't recognize any of those 6 and there's any irregularity in the wall, then then you can basically say it's malignant, except your mucinous cystadenoma, which is that multiloculated Swiss cheese. Okay, so key points. We should be using standardized technology to describe ultrasound images. I've mentioned those papers, but there they are. So it's adnexal lesions, it's the IOTA consensus statement. The endometrium uterine cavity is IETA. The myometrium is the MUSA, and the deep infiltrating endometriosis is the IDEA. So those of you going to RCOG Congress, I'll be talking about the 4th one on Tuesday afternoon. So when in doubt, refer for a second opinion. Thank you very much. Any questions?
Thank you.
I think I've opened up all this water.
It will be very, very quiet on the other side.
I need to take this out, but I can do it later.
Yes, okay. Do you have any question? Hermos.
Douglas, I would call this gynae scanning made easy, isn't it? That's how it, 20 minutes, done it all. Now, so if you see any of these abnormal structures and get confused, that's not my area either. They're multiloculated, solid, cystic, and this and that. So, biopsy and histological confirmation, is that what you recommend? And in pregnancy, is that any different, the approach?
No. So pregnancy depends on which trimester you're seeing it. So there was one study with DeVore, also King's, looking at, they followed up a whole lot of ovarian cysts, and most of them disappeared as you went through the pregnancy.
So leave them alone?
Leave them alone. Yeah. But
if they're not pregnant, how do you... Sorry. In non-pregnant situations, how do you just give the audience an approach of how do you then confirm?
Well, essentially, I'll look at the different type of cyst that it is. Because if it's a unilocular cyst, for the most part, we ignore it. And we just follow them up 3 to 6 months later, even if the women are postmenopausal. If you start seeing irregularities or color, or you start seeing cystic solid or solid lesions, then we worry. So any solid lesion needs needs either laparoscopy or laparotomy. Whereas the rest, you can watch or you refer. The role of tumor markers, oncologists always tell us we should be taking tumor markers, but if you look at all the publications that come from OTA and from studies, there's no value in CA125. It doesn't add anything to your diagnosis. Everything is grayscale pattern recognition. But I mean, Tom Bourne is talking tomorrow all about this, so we'll see if there's an update on that.
Another question.
I think another thing we must take into consideration is subacute torsion of the ovary. We can also present as a complex cystic structure of the ovary. Can you comment on that?
Yeah, your subacute torsion, the single the symptom that comes with torsion or subacute is sudden onset of nausea and pain. Okay, so that's the first feature they should look at. And second of all, if you look at the studies, you can compare the two ovaries. Okay, so there are ultrasound features that are suggestive of a torsion. So especially if you've got a normal looking ovary to compare it with, a torsion often, some people say a normal ovary can't tort. So there'll often be a cyst on that ovary, be it small or big, there'll be a cyst that's there. In terms of when you look at it, the structure itself, there'll be a whole lot of peripheral cysts that you often see on the ovary. The ovary tends to be larger than the other one. And if you put color on there, speak of a whirlpool sign, where you can actually see the vessels that are within the pedicle that might have a whirlpool appearance. But essentially, the only way you could really exclude that is with diagnostic laparoscopy, if you're that concerned. And that obviously you need your clinical picture, because if she is symptomatic and she's got peritonism, she probably does need a laparoscopy.
Well, I think it was a great compliment to you that Hermos said that it was gynecology made easy, because this is really the objective of a basic training, to bring it down to the essentials.
I do have one more question though. We have time.
Yeah, lots of time.
We learn a lot of basics at medical school, but when we are in clinical practice, we see things slightly different. For example, if we take patients who come to us for ultrasound of a fetus after infertility, more than 50% will say that at the infertility workup at the infertility center, there was a uterine septum which was successfully removed. What is your view of the true incidence of the uterine septum, and how easy it is to see it on ultrasound? Can you see it?
Yeah.
Uterine septum?
Very easy.
Just by looking at it, or do you put any fluid in it?
No,
or-
just by looking.
And how common is it?
Very uncommon. No.
The 50% that I'm quoting is an infertility specialist imagination.
Yeah, I mean, so just to give you an idea, I've been scanning for 10 years in private practice, and I've probably got 3 uterine abnormalities that I've picked up antenatally. So basically, the easy way to pick it up is, remember I showed you, you've done your longitudinal view, then you've switched across to transverse, and then what you do is you scan from the cervix up to the fundus, and you just watch the endometrium. So what would happen is, as you go up, normally you see the endometrium that stays as a solid one, okay, and then at the top, it disappears, if you can follow that. And then what will tend to happen in fundal abnormalities is you'll see that endometrium splits. So when you get to the top, you'll see that there's a pocket of endometrium and a pocket of endometrium. And obviously it depends on that septum. So if you look at the evidence, even if you have an arcuate uterus, there's evidence that they had increased risk of miscarrying in the first trimester. It's very difficult to tell a patient when she's 18 and she's seeing you and you've seen that she's got an arcuate uterus that she's got a risk of miscarriage. So I don't actually tell them that they've got an arcuate uterus. But obviously if there's a septum, then that's a real risk. And what you tend to find is that it's often picked up by the infertility guys because the patients will present for investigation of their recurrent miscarriage. And then when you do your scan, you can see it.
Well, we have a question. Yes, that's what about a minute ago. Is adenomyosis in adenomyosis, please elaborate on fan shadowing.
Okay. I mean, essentially, it's just when you see it enough, you'll just appreciate. So, if you have, for instance, a dermoid, okay, and you have a white nodule, then what tends to have, you have acoustic shadowing after that. So you can imagine that white nodule, and essentially the shadowing behind the nodule is linear. So essentially, it's no bigger, no smaller. It's basically because the nodule itself has absorbed some of the ultrasound beam, and therefore there's a fallout behind it. Okay, with adenomyosis, you get literally this fan-shaped shadowing. So it's not limited to just one area. It tends to be wider, like a fan.
I have another question regarding the septa, because I saw recently in a pregnancy a septum which was not fundal but quite low, and the placenta which was implanted on the posterior wall was also implanted on the septum and then on the anterior wall. So it's something which I've never seen before. Do you think that this woman had a history of DNC? Would you interpret this as a kind of a synechia, a kind of a consequence of the DNC? Because it was not starting from the fundus. It was, let's say, half away on the right.
I mean, it is unusual because if you look at the way that uterine abnormalities develop, it is a fundal.
Yes.
Because essentially in embryology, there's the absorption of the inner lining of the womb, and therefore you get your heart-shaped uterus. So I've never seen a fundus, but it begs the question then, it might be a consequence of a DNC or some trauma that you've got the synechia which has developed. Yeah.
That was also my interpretation.
You said that cysts in pregnancy one should leave, and I'm sure that's true for the majority of them, but there must be a few that the more suspicious cysts in pregnancy would have papillary projections, solid components, increased vascularity. How would your approach be to those in pregnancy? And also would your approach be different in the first trimester versus the last trimester?
Yeah, so essentially, if you're going to operate an ovarian cyst, they do say that it should be in the second trimester because your risk of, first of all, you need to ascertain that, for instance, your nuchal is normal, so that you're not having a chromosomally abnormal baby. But also, if you look at the data, presumably you're going to do laparoscopic surgery. But if you're going to do laparoscopic surgery, the 22-week period is the time that you should be operating. In terms of the papillary projections, it is interesting because there are hollow tumors that become more vascular in pregnancy. So there's this decidulized endometrioma in pregnancy, and essentially that's so people have been it's an endometrioma, which you know it's an endometrioma because you've seen them pre-pregnancy, and it undergoes change in pregnancy and it becomes quite vascular. And if you looked at it for the first time in pregnancy, you'd think it looks like a malignancy. So, I mean, essentially it is difficult. It's very rare. I mean, you might see one or two in your lifetime. They're big, so they tend to be the borderline tumors. And they often end up, the really big ones need laparotomies, which you have to do later. But it's one of those things, you have to get lots of people on board. So you need to scan, make sure that you see what you're seeing, you get the oncologists involved. And it's often a difficult decision to go and operate. But your basic principles apply, and that if you're starting to see solid projections and fluid and ascites, then the chances are it is malignant, but it's incredibly rare.
I'll ask a question, Douglas. Can you comment on the features in pelvic inflammatory disease, which of course in our communities is quite common?
In terms of
adnexal appearance.
Yeah, well, the hydrosalpinx are the ones that you've seen there, and that can be quite bizarre. So essentially, that's a tubular structure that you're going to be seeing around the uterus, and it depends when in the inflammatory process that you are seeing it. In terms of, we very rarely get to see acute gynae in terms of PID because they've often they'll be seen by the casualty officers. But ideally, you might not see anything in the acute phase, and that hydrosalpinges progress with time. And then it's basically it's just seeing how the hydrosalpinx evolves. In terms of acute PID, there's no real ultrasound features other than what you would find on a clinical examination. In terms of, you'd find cervical excitation, tenderness, and maybe some fluid and tenderness around either ovaries. But acutely, you're not going to see any ultrasound features of it.
Okay, thank you very much.
My pleasure.
You got a lot of questions.